So, so hey, I believe we all remember these diagrams. Like, to make it easy, we will split the abdomen into 4 quadrants, like from midline through the umbilicus down to the pubic symphysis, and from the umbilicus, another horizontal line. That way split our abdomen into 4 quadrants: right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant. Why is that important? Because it tells us what is underlying in which area. So let's say if you are examining a patient, and if you put your hand in the right upper quadrant, and if you feel something, like if you feel a lump in that region, then you will say, hey, right upper quadrant swelling, it could be coming from the gallbladder, it could be coming from the liver. That's it. So let's say, how about left upper quadrant? Left upper quadrant, so it is, if we look at that, it's mainly stomach, isn't it? Might be small portion of the liver, but it is mainly stomach. So stomach is a hollow organ, tube, like a bag. So we don't really, like it is not natural, normally easy to feel the stomach, because you feel a bag, unless the stomach is really full or the stomach has got lump, like for example lymphoma, loss of lymphoid tissues in the stomach, and then that's become tumor, lymphoma, or the stomach passage has been blocked, and then we can feel the stomach. Look at the spleen here. Spleen is small. It is well underneath the ribs. So normally we do not feel the rib. And look at that, the spleen is just here. It is far away from the edge of the rib. So we will not be easily able to feel the spleen. But when we can feel the spleen somewhere around here, even the small little tip of the spleen, that means the spleen has enlarged to a significant size. At the same thing, like right lower quadrant, like we have the cecum and appendix. So the patient with appendicitis usually complain of the right lower quadrant pain. And these left lower quadrant, we can see the sigmoid colon. And in elderly patient, where sigmoid diverticulosis or sigmoid tumor, they complain of pain in the left lower quadrant. So how do we know that? Because we have this knowledge. So all the anatomy students need to take this information: right upper quadrant, left lower quadrant, left upper quadrant, right lower quadrant, and left lower quadrant. So that is the basic information, especially for the palpation. Like when you feel somebody's abdomen, this is what you are trying to feel. Okay, so let's say if you want to be a little bit more specific, so for those like who are going to nursing, for those who are going to medical school, you need to have this knowledge, which is the 9 regions of the abdomen. So this is the medical school or the nursing school knowledge. 9 regions of the abdomen. How do we split the abdomen into 9 regions? Yes, these 2 lines here, proximal to distal, they are called mid-clavicular line. They cross the midpoint of the clavicle, mid-clavicular line, right mid-clavicular line, left mid-clavicular line, and we will draw 2 horizontal lines. One line is just crossing the abdomen, just underneath the rib cage. Look at that rib. It is costal cartilage, isn't it? Ribs, costal cartilage. So we would say it is just touching the lower end of the ribs. So we give it a name, subcostal plane. Sep means below, costal means costal cartilage, plane, this subcostal plane. And another line is we have to palpate the ilium starting from the anterior superior iliac spine, gradually follow to the back and nearly highest point. There is a little bump in the ilium that is called tubercle of the ilium. So the tubercle, two tubercle on the one on the right, one on the left connect. So that's imaginary line again. Imaginary line drawn crossing the let's say highest point of the ilium. And that's another horizontal line. Now we got the 9 regions of the abdomen. So what are they? Just underneath the rib cage, underneath the costal cartilage, right hypochondrium. Hypo means below, chondrium, costal cartilage. Left hypochondrium. And then in the upper here, that is epigastrium. Epigastrium, where is epigastrium? And then the right inguinal or right iliac, left inguinal or left iliac region, because it is close to the ilium. And this is epigastrium. So this is the epigastrium. So we will have the top one is epigastrium, then the most bottom one is hypogastrium, or just above the pubis, so suprapubic region. And in the center where our umbilicus is, we say, hey, umbilical region. So now, and then here on the right lumbar region and left lumbar region. So now we got the 2 hypochondrium, 2 inguinal or 2 iliac, 2 lumbar region, and epigastrium and hypogastrium and umbilical region. We got now 9 regions of the abdomen. This is a little bit more specific because it split the abdomen into further detail comparing to the just 4 quadrants. So what is the importance? Hey, epigastric pain, the pain in the epigastrium, epigastric pain. You can see stomach there, you can see the liver here. And at the same time, liver, after the diaphragm, we have the heart. Our heart is here. So our heart is here. So epigastric pain could be coming from the heart, from the liver, or from the stomach. The same thing like right lower quadrant. Hey, it is coming from the cecum, the big beginning of the large intestine, or appendix. It is a little bit naughty for them to draw this appendix into the hypogastric because appendix pain is in the right iliac region. So if you want to say appendicular pain, it is mainly in the right iliac region. Of course, it can extend into the hypogastric or suprapubic region. And for the female, we have ovaries, right ovaries here, left ovary here. So iliac pain in female could be coming from the cecum, appendix, or the ovaries. And the same thing go on and on and on. If you look in the center, umbilical region, we only have small intestine. We might have large intestine. So that is the way we divide the abdomen into 9 quadrants and 4 quadrants and 9 regions. So if we look at the abdomen, so why is it important? Because for the palpation, when we examine the abdomen, that is where we put our hands on somebody's hand. In this region, we know what is underneath our hand. So if we put our hands in this region, what we are trying to feel is we are trying to feel the cecum and the appendix. If we put our hands just around the umbilicus, we will be feeling the small intestines. If we put our hands in the right hypochondrium or epigastrium, then we will be feeling where we are trying to feel the liver. So it makes more meaningful when we do examination, physical examination for the patient. And also when we do the surgery, operation, when we do the operation, or even, when you see somebody's tummy, and if they have a little scar on their tummy, you can predict what sort of operation they had. So if someone has a little scar on here or there in the right iliac region or right lower quadrant, that means they might have an appendix operation. If they have a just like an incision just above the pubis, this is the pubis, and this is, if the incision is just all along the pubis, then that is a Fenestree incision, which might be cesarean, lower segment cesarean section. Like they might have a baby through this incision. So for the delivery cesarean section, it is mainly these days, it is just going along like that. And for the operation on the urinary bladder, operation on the prostate, they will also go along this incision. And look at that gable incision. It's just like a dome-shaped incision. It is for the, it's very rarely seen. It is mainly for the liver transplant. And if you look at your grandma, might not be mom's, because the coccus incision, it is pretty old now. We don't really want to use this incision because it is not along the Langerhans line. And if you look at this incision, just along the subchondral region, and this is going to be for the gallbladder. So we don't see this coccus incision anymore. We are gradually more and more going to the like a minimally invasive laparoscopic surgery, and it is rare to perform this coccus incision. But now if you see a person, his abdomen, and if you see a scar, you can relate this scar and the underlying structure and what the surgeon was trying to achieve. Okay, let's move on. So what about these incisions are more common, like longitudinal incision. Like this is in the midline, so midline incision, easy to remember. Again, like it is along in front of the tummy, just going from the sternum to this pubis symphysis, midline incision. If possible, we prefer not to do that because it is pretty painful, because it is not along the skin crease. So the Fenestree incision is along the skin crease. So the healing is much better, the scar is much better, post-operative pain is much better. But, like the skin crease is going horizontal, and if we are cutting the skin in longitudinal direction, then we are crossing the skin crease. It is a bit more painful. The chance of wound gaping is higher. But why do we need to do that? Because it is a lot easier. Just if we are not sure, we just cut the abdomen from top to bottom, let it open and have a look. It is quick, it is user-friendly, but it is not that good for the patient. But in case of emergency, we have to do that. That is the midline incision. And of course, if we are slightly off the midline, then we will say paramedian. Look at that. This is left lower paramedian and right upper paramedian incision. McEvedy, it is for the what do you call that, femoral hernia. So it is in the groin. So now at least if you see a scar, you know what operation this person had, and especially if you see a longitudinal midline incision, again, like we don't see these sort of infection, not many now, thanks God, because these are more emergency operations, and it is a bit painful because it is crossing everything, because the skin crease is horizontal and we are cutting we are getting like perpendicular, and when we sit down, you know, this incision just fold and bend, and it's just split the wound. Wound gaping is higher. We don't like that. But in case of emergency, easy to perform, just go straight. So now, if you know the incisions, skin incisions, and you can predict what sort of operation they have, and you can predict what sort of organs they do have under the skin, inside the abdomen. That is what we are trying to relate. That is all about anatomy. So of course, you know, let's say if I give you a scalpel, like knife, and let's say if you have a chance to open somebody's abdomen, you are going through the knife you are using is going through the skin. Yes, skin. Skin is skins include epidermis and dermis, and underneath the skin, hypodermis, and then you will get to the deep fascia. Of course, this is in the arm, so we'll get to the muscle. But what do we cross? What structures are we going to cross when we make an incision on somebody's abdomen? So now this is the abdomen, anterior abdominal wall. You can see the ribs here. The ribs here are covered. And as we say, you know, anything in our body, if we don't know, 3. So intercostal muscles, 3. Meninges, 3. What do you call that? The layers of the artery, 3. Tunica intima, media, adventitia, 3. So the same thing like abdominal muscle, 3. What are they? They are external oblique, internal oblique, and transversus abdominis. External obliques, the direction of the external obliques can be from outside to inside. So outwards, from downwards, going downwards, and medially into the center, downwards and medially. So let's say if you have in the exam, if you have a cadaveric specimen, and if we ask you in the anterior abdominal, what is the muscle? What is this muscle? I want you to look at the direction of the muscle. And if the direction is like the way you are putting your hands in your front pockets of your jean, downwards and medially, it is the external oblique muscle. Look at the direction. It is going downwards, it is going to the medial, it is not going to the lateral. If we remove this external oblique, underneath we have internal oblique muscle. Internal oblique muscle is going downwards and laterally. Hey guys, it is downwards and laterally. So the way you put your hands in the back pockets of your jean is going downwards and laterally. The external oblique is into your front pockets of your jean trousers, downwards and medially, and external oblique, internal oblique is downwards and laterally. And of course, and we have to have 3 layers. So we have the transversus abdominis. Transversus abdominis is going horizontal, horizontal, horizontal. But these muscles, they are more on the lateral side of the muscle. And if you look at that, this external oblique became a flat sheet, white flat sheet. That is what we call aponeurosis. So the muscle coming from the back and originating from the ribs, these muscles might be somewhere around the mid-clavicular line. The muscle become gradually changed into the connective tissue, which is called aponeurosis. So aponeurosis, tendon, they are structurally the same, you know, fascia, aponeurosis, tendon, structurally they are the same. They are dense connective tissue. Those from the endomysium, perimysium, epimysium. So these connective tissue from the muscle gradually combine together to form a thick, flat sheet of connective tissue. So this external oblique muscle around the mid-clavicular line gradually change from muscle to become aponeurosis. So the same thing, you know, this internal oblique muscle as well, it will change in the middle region. it will change into the flat aponeurosis. The same thing, if you look at the transversus abdominis muscle, it will gradually change into aponeurosis. So muscles on the lateral side coming downwards and medially or outwards and laterally or transversely, whatever they go, just whenever they get close to the midline, around the mid-clavicular region, they gradually change, the muscle gradually disappear, and they gradually change into aponeurosis. Aponeurosis is nothing more than the dense layer of connective tissue. Right, so these aponeurosis, so we will have three aponeurosis. Aponeurosis coming from the external oblique, aponeurosis coming from the internal oblique, and aponeurosis coming from the transversus abdominis. So these three aponeurosis, they will make a mesh close to the midline. And if you look at our rectus muscle, as we know, rectus muscle, rectus means straight muscle coming from the top to the bottom on the left. There will be another rectus muscle. We have to remove this aponeurosis coming from the external oblique to see the right rectus muscle here. And two rectus muscle here. Inside, there is no muscle, only in the center, there is no muscle, only the aponeurosis, it will be there. So therefore, midline incision is so easy to perform, like you don't damage the muscle, you just stay in the midline. So you push the left rectus towards the left, you push right rectus towards the right, and then you just stay in the center and you don't damage any muscle. So which is very easy. That's why in case of emergency, we have to do the midline incision. We right in between two rectus, there is no muscle. We just go there straight away. So that is the arrangement of the muscles in the front of our anterior abdomen. Of course, at the back of the abdomen, you know that already. It's too boring for you guys. The trapezius muscle, which is triangle, and the latissimus dorsi muscle here, and aponeurosis over the latissimus muscle. And this is the ilium. This is the ilium on the left. This is the ilium on the right. When we say transtubercular line is the, if we follow from the front, just close to the highest point, we have a little bump in the ilium. That is the tubercle of the ilium. So we connect the two ilium here, two tubercles here. That is the transtubercular line. Okay, so posterior abdominal wall is not very exciting. Posterior abdominal wall is not very exciting. We will just move on to the anterior abdominal wall. So as we say, you know, we were doing an operation, and then, hey, so let's say in the operating room, you are my trainee and I let you do the operation, and we are starting with the simple operation. Okay, hi guy, yes, this is your scalpel, this is your knife, go and open the abdomen. Then you say, hey, we go to the, it is an emergency, we stick in the midline. So midline incision here. So midline incision here. And what structures are we going to cross? Of course, here, skin, which means epidermis and dermis, hypodermis, and then fascia. And then we go to the midline here. So in between the two rectus, this is the right rectus, this is the left rectus, and we just, hey, split the fascia. Once we split the fascia, we see the peritoneum, which is lying inside, and then we get inside the abdomen. So that is the beauty of this midline incision. It is easy to perform, and it just goes straight in between two rectus muscles. But we need to know the anatomy. And as we say, we got three muscles in the anterior abdominal wall. The outermost is external oblique, which is running downwards and medially. middle layer is internal oblique, which is going downwards and laterally. And transversus abdominis, it is going horizontally. And this is the cross section of the anterior abdominal wall. This is the right side. This is the left side. This is the anterior abdominal wall. That will be posterior. And we are going here. So if you look at that, guys, so from the transversus abdominis muscle, we become aponeurosis of the transversus abdominis. Internal oblique, we become aponeurosis of the internal oblique. External oblique muscle, we become aponeurosis of the external oblique. And if you look at that, this internal oblique aponeurosis split into two, and anterior portion of the internal oblique will fuse with the aponeurosis coming from the external oblique muscle, and posterior branch of the internal oblique aponeurosis will fuse with the transversus abdominis aponeurosis, and they fuse like that. And that is the way they swallow the rectus muscle. And from these right and left side, they meet in the center. They meet in the center. This center is called linea alba. So this along here in the center here, it is called linea alba. Linea means line, alba means white line, because there is no muscle. There is only fusion of the aponeurosis of the right side and aponeurosis from the left side. So it is only connective tissue aponeurosis. So the good thing, as we know, it is simple. There is no blood vessel, easy, go in. But the bad thing is, it is not very good with the wound healing. So we have to stitch it back properly, carefully. Otherwise, we can get hernia through the surgical incision. So now you have, with the knife, you just slash it open through skin, subcutaneous tissue, and through the linea alba. There is no blood, bloodless free. Just push the right rectus on towards the right, left rectus towards the left. And now you see the peritoneum, open the peritoneum, and now you are inside the abdominal cavity. Hey, it's easy. So what about this sort of incision? A paramedian incision, like just off the midline incision. So they will have to go through here, cut here, open the anterior sheath of the rectus, split the rectus, open the posterior sheath of the rectus, and then go into the abdomen. So it is slightly longer time consuming, but the healing rate is much better, because, and the incisional hernia rate is less, because you are going through the muscle. So when we close it, the muscle will be closed and the healing is much better. So let's look at the anterior abdominal wall a little bit more carefully, because if we want to do surgery, the surgery is based on our anatomy knowledge. So now we can see more clearly the external oblique, internal oblique, transversus abdominis. They will gradually become aponeurosis, 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 internal oblique aponeurosis split into two, and anterior portion of the internal oblique will fuse with the external oblique aponeurosis. Posterior division of the internal oblique will fuse with the transversus abdominis, and then that is the way they just split open, swallow the rectus on the right side, split open, swallow the rectus on the left side, and they meet in the center. And this center is pretty wide because it is just the fusion of the right and left aponeurosis, and there is no muscle, and therefore we call it linea alba. Linea alba. So now I believe it is a little bit more clear. This is the cross section, as we know. This is the right side, this is the left side, and this is anterior, and this is the intra-abdominal. So I'm just going to make it a little bit more clear. So now we can see much better. External oblique, internal oblique, and transverse abdominis. Internal oblique split into two: anterior portion, posterior portion, and anterior portion will fuse with the external oblique aponeurosis. And that's the way they create a pouch. So we call it this anterior sheath of the rectus, and this is the posterior sheath of the rectus. This is the right side, there will be left side. This is the linea alba. So once after that region, there is one layer, which is the peritoneum. If we split the peritoneum, we get into the abdominal cavity. So this is the reminder of the body cavity, ventral body cavity, and dorsal body cavity. And our abdomen is one of the ventral body cavities. Now we will just split open and get into the abdomen after getting the peritoneum. So hey, now we get into the split the peritoneum, and then what are you going to see? Oh my God, the flat sheet. So flat sheet of fatty tissue. Oh, what is that? Oh my God. Wait, this fatty tissue is called omentum, O-M-E-N-T-U-M. What is omentum? Omentum is just like, like a fat and blood vessels and mesentery, and it is just like, we call that policeman of the abdomen. It is just hanging in the anterior abdominal wall inside, like an apron. And whenever there is inflammation, so let's say if someone has pelvic appendicitis, these omentum will go to the appendix and just try to wrap it up, so that just to stop the spread of the infection from the appendix. So this is the omentum. And what do we have to do is we have to lift up the abdomen. Hey, just go away, lift it up. I want to see, go to the intestine of the inside the abdomen. And then now if we lift it up, now that's what we are going to see. Ha ha ha. Not a good drawing, but yay. So this is the esophagus. Esophagus is the swallowing tube. So when we eat food, the big burger we eat, we get into our mouth. Hey, we are anatomy students, so we will not say it is mouth. We will say it is oral cavity. Yeah. So oral cavity, the food inside the oral cavity, you chew. You might not even chew, you just swallow it. Swallow a big burger. So this burger from the oral cavity go into the oropharynx, and then through the laryngopharynx, and then finally it will be directed towards the esophagus. And esophagus is a long tube from the oropharynx to the VO, also 10 inside the abdomen, and then we will get into the stomach. Yeah, this is the stomach. And then after stomach, when you leave the stomach, it is tubular structure. Stomach is a big bag, and then now it will become a tubular structure that is called duodenum, D-U-O-D-E-N-U-M. Duodenum is a C-shaped loop, and then it will be followed by jejunum, J-E-J-U-N-U-M, and jejunum will be followed by ileum, I-L-E-U-M, and then ileum will become the cecum, which is the beginning of the large colon. So this junction is called ileocecal junction, because ileum coming into the cecum, and this cecum will continue upwards as a colon, C-O-L-O-N. So this is going upwards, so ascending colon, and from the right it crosses to the left. So this is crossing colon or transverse colon, and then transverse colon will come down on the left side of the abdomen, which is called descending colon, coming down, descending colon, and descending colon will become sigmoid shape, and therefore we call that colon sigmoid colon, and finally that will become rectum and anal canal. So that is our arrangement of the intestine in our body. So the ascending colon, descending colon, now we look at that. So where the esophagus here, we come into the stomach. Stomach is a big bag, and then leave the stomach and continue as the duodenum. And the small intestine, which is made of ileum and jejunum. Jejunum will come and join, come into the cecum, and cecum will continue upwards as a ascending colon, and then cross transversing colon, and then come down descending colon, and then become a sigmoid shape. We call it sigmoid colon, and finally become rectum. Rectum means straight. So here they have drawn a rectum slightly straight, but rectum is not 100% perfect straight. It is slightly curved as well. So rectum, and finally come out as a anal canal. So that is the arrangement of these. If we just lift up the what you call the omentum, it is really big, flat sheet of fatty tissue. So it is big. So we'll say, hey, it's a greater omentum. Because it is big, it's greater omentum. We have to lift it up to see the what do you call that? All the intestinal structures. Okay. And now, if we want to look at these, the whole intestinal structures on the radiograph, because the intestines, the lumens, filled with air and food and water. So if we want to make a picture of that, we give the patient barium. Barium is radio opaque. So ask the patient to swallow barium, and then just take X-ray, like depending on the protocol, like might be every 30 minutes or might be every hour. And then we just follow the barium going. So the barium will be going from esophagus, the barium will get to the stomach, the barium will get to the duodenum, the barium will get to the jejunum, the barium is keep going into the ileum, into the cecum, ascending colon, transverse colon, descending colon, sigmoid colon. And then we do X-ray, like depending on the protocol, might be every hour or might be every 2 hours. And then if we keep tracing the barium, and we will identify the anatomy of the gastrointestinal tract. And this examination is called barium follow-through. So we just follow through with the barium. And if we do that, that's what we are going to see. This is the barium follow-through, guys. So the patient has been given the glass of barium, and then just they have to swallow it, and then that barium got to the stomach here. This is the stomach, and the barium starting to leave the stomach in the duodenum, and then becoming jejunum, and jejunum, look at the loads of jejunum, and then gradually continue as the ileum, and then gradually we go into the cecum and ascending colon, transverse colon, descending colon, sigmoid colon, and rectum and anal canal. Hey, so what difference can you see between ileum and jejunum? This is the jejunum. This is the ileum.
The jejunum looks like it has like ring-like structures and more grooves.
So it is just like, what do you call the accordion? Like accordion, or that's just like more like the ileum is pretty cool guy. Hey, it's just like a tube, it looks like it doesn't care. So here we call it ileum is characterless. There is no characteristic. So that is the ileum. And jejunum is more like an accordion-like, like a lot of lots of vertical structures together. So in other way, we call it concertina effect. So if you see the concertina effect, you can say it is the jejunum. And if you see a little bit characterless, there is no character at all. Like it just look like what you call that. I'm sorry to say, like a condom. If you put fluid in the condom, it is just like that. There is no character at all. So this is the ileum, which is the characterless structure, and this is the jejunum, which is more like a concertina effect or accordion-like effect. So I want you to take a, what do you call that, photographic memory of this. This is really lovely because, when you see the abdominal X-ray, you are going to see similar pattern. Of course, because normal plain abdominal X-ray, it is there is no barium in it, so we will not see as clearly as like that. But we are going to see similar pattern. And jejunum is concertina effect, and ileum is just a characteristic, no characterless. There is no character at all. And finally, that's ileum will go into the cecum and ileocecal junction. And this is a little bit naughty structure, large colon, boom, 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 horstrations like boom, boom, boom. So this is the feature of the colon. So this is the ascending colon. This is the ascending colon. This is crossing. So this is transverse colon. And now it is coming down. Barium is coming down, which is called descending colon. And finally, it will become a sigmoid shape, and then going into the rectum and inner canal. So this is again really, really lovely structure. So I want you to take a photographic memory of jejunum, photographic memory of ileum, photographic memory of the large intestine, and make your life a lot meaningful when you see the abdominal X-rays. And this is from our textbook. Again, like it is so beautiful, like cecum, ascending colon, transverse colon, and descending colon, and become sigmoid shape. We call it sigmoid colon, rectum, and finally it will come into the inner canal. But here, what I want you to remember is this, the right colonic flexion. So from ascending to transverse, there is one bend, like nearly 90-degree bend, and left colonic flexion. So this is another bend going from horizontal to coming downward. It is more like a more steep bend, isn't it? It is going into the what do you call that? Going close to the spleen area as well, and it is higher. Left colonic flexure is higher than right. The reason is we have the liver on the right side. So the right colonic flexure cannot go really up that far because we have the liver here. On the left side, the spleen is small, it's pretty far up in the back, so it's just go there. And the descending colon, sigmoid colon. And so, it is, now what we have done is we have looked at somebody's abdomen, and if we see any scar, we can predict what sort of operation they have been through. If you put our hands on somebody's tummy, we know what organ we are trying to feel, and then inside the abdomen. And number three, if we do an operation on somebody's tummy, we know which structures we are cutting, like skin, subcutaneous tissue, linear alba, splitted peritoneum, get into the. And when we get into the abdominal cavity, then we will see a flat sheet of fatty tissue that is omentum, which is big, so greater omentum. And then if we lift it up, then we see the intestine. And so now we see the stomach, duodenum, jejunum, ileum, secant, ascending colon, transverse colon, descending colon, sigmoid colon. Yes, you know, some of these colons are stacked to the posterior abdominal wall. Some are just hanging and floating inside the abdominal cavity. So for example, like secant and ascending colon and descending colon, they will be stacked to the posterior abdominal wall. But something like transverse colon, they will be hanging down inside the abdomen, and they can move around along the mesentery. So we will need to talk about the mesentery. So something like a duodenum, duodenum is stacked to the posterior abdominal wall. But this jejunum and ileum they will be hanging inside and floating and moving around inside the abdomen along the mesentery. So we need to know what mesentery it is. What is mesentery? But at the moment, we just follow the order: stomach, duodenum, jejunum, ileum. The characteristics of the particular segment, like jejunum is concertina effect, and the ileum is characterless, there is no character at all. And the large bowel, the ascending, transverse, and descending colon, they have got boom, 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 boom. The hostration. That is what you can see here. So now I believe you are familiar with this. We have the liver here on the right hypochondrium and to some part of the epigastrium. And we remember our friend aorta, thoracic aorta coming into the abdomen as abdominal aorta. And this abdominal aorta dividing as a right common iliac and left common iliac arteries. And we said the branches of the abdominal aorta. It is easy to remember. I believe you all remember that paired branches and unpaired branches. Paired branches are going like a perpendicular, like a renal artery, right renal and left renal, and right gonadal and left gonadal artery. These are the pair, right and left, right and left, right renal, left renal, right gonadal, left gonadal. And we know that the only single unpaired branches coming from the anterior surface of the abdomen. These are the three, which are celiac here, celiac artery, celiac tract, superior mesenteric artery, where is superior mesenteric artery? And inferior mesenteric artery here. So these are the not paired and paired branches coming from the anterior surface of the abdomen. So the question is easy. What are the unpaired arteries of the abdominal aorta? Celiac, superior mesenteric, inferior mesenteric. That's easy. So because, you know, it is more important in life. It is more important in life. You look at the celiac artery. Celiac artery is giving a branch to the liver. So that is the common hepatic artery going to the liver. So liver hepatic. So when it gets close to the liver, it will divide into right lobe of the liver, left lobe of the liver, right hepatic, left hepatic. But from the celiac, it's continue as the common hepatic artery, common together. And it will go another big branch here. You can see the celiac going branch here. Torches. And then going to the spleen, splenic artery, guys. So it is easy to remember from the celiac tract, common hepatic artery, splenic artery. And there is a little branch, which I want you to appreciate that. That little artery is called left gastric artery. Look at that, the way it is going. It is running along the lesser calf. So this is a small calf, the lesser calf, and this is the big calf. So lesser calf and greater calf of the stomach. And this is the left gastric is running along the lesser calf of the stomach. Bang. And if you follow the superior mesenteric artery, if you, where is superior mesenteric? Hey, it's here. Oh my God, it is giving the blood supply to the jejunum, ileum, and might be part of the ascending colon, and it gives branch down to the right two-thirds of the transverse colon. So this superior mesenteric is really important because it is giving all the blood supply to the jejunum, ileum, and transverse colon. And how about duodenum? Duodenum got a blood supply from the branch from the common hepatic artery. What about the inferior mesenteric artery? Inferior mesenteric artery. Inferior mesenteric artery gives distal portion of the large colon, like left 1/3 of the transverse colon, descending colon, sigmoid colon. That is, these organs are supplied by the inferior mesenteric artery. So there's only 3 arteries, which is without any pair, and pair 3 arteries coming up in front of our abdomen. They are so useful. They are so useful. And now, you know, like as we say, like everything in life, if we don't know, we said 3. So now these 3 arteries coming out from the anterior surface of the abdomen. You now know the upper portion is going to the upper part of the abdomen, middle portion is going to the middle part of the abdomen, and lower portion is going to the lower part of the abdominal structures. So it is so easy to remember. And once somebody get old, you know, like for those who smoke, who has diabetes, smoking, high cholesterol, and then the atherosclerosis, blood vessels become smaller and narrower, and they can get narrow blood vessel in the heart as a coronary artery disease. These people, they can also have the narrowing of the blood vessels of the celiac or superior mesenteric or inferior mesenteric. If that happened to superior mesenteric, they come with the small intestine ischemia, the way they get the myocardial chest pain, you know, they also get the insufficient blood supply to the intestine, and then they got vague abdominal pain. So elderly, old, a little bit old patient who smoke, who diabetes, who has high cholesterol, they got vague abdominal pain off and on. Need to think about that. Superior mesenteric artery is just narrowing of the superior mesenteric artery, and the guts are not having enough blood supply. So anyway, this is the blood supply for our gastrointestinal tract in the abdomen. And we keep talking about mesentery. What is mesentery? Mesentery is just a twofold of peritoneum. Like as we say, we have pericardium in our heart. We have pleura in our lungs. These are the coverings of the vital structures which are moving. And we also have covering inside the abdomen, which is called peritoneum. This peritoneum is trying to cover all along the intestine from duodenum, jejunum, ileum, and then just fleshy folate come back. They try to tie the intestine and back to the posterior abdominal wall. And sometimes they can get it right, sometimes they get it slightly different. And some structure, they just stack on the posterior abdominal wall. Some structures, they are hanging along with the mesentery, which is made of 2 peritoneal fold. We'll talk about a little bit more detail later. And so that because of the mesentery, which is the attachment of the intestine to the posterior abdominal wall, this intestine has some degree of movement, like the dog with the little leg. And some intestine like ascending, descending colon, they will be stacked down to the posterior abdominal wall. Duodenum will be stacked down to the posterior abdominal wall. So now this is in the cadaver. It makes more sense now. This fatty sheet of tissue just covering everything over the intestine. It is called omentum. It is big, therefore we call it greater omentum. And the now liver in the right upper quadrant or right hypochondrium and the epigastrium. We can see the cecum on the right iliac fossa. And small intestine, they are mainly in the umbilical region. Okay, so let's keep going through the a few more slides before we take a break. So keep looking at that. This is the omentum. Now we have lifted up the omentum, greater omentum being lifted up, and you can see the mesentery here. Mesentery. Oh yeah, mesentery. Mesentery is the two-fold stacked together of the peritoneum, which is pulling the intestine to the posterior abdominal wall. And sometimes mesentery, they do that. Sometimes they just stack the intestine back to the posterior abdominal wall, and they do not have mesentery. And this is the sagittal section. So we have to follow the peritoneum. Like this pericardium, pleura, we have two layers. So the thing we have to remember is like our abdominal wall is acting as a boot, big boot Nike, and we have to wear two socks. One sock is to stack on the boot side, and the another sock is on our feet side. So the same thing like the peritoneum, we have the visceral peritoneum, which is on the side of the intestine, and parietal peritoneum, which is on the side of the abdominal wall. So guys, so let's take about 15 minutes break. I hope it is not too much. We are going to divide this gastrointestinous, intestinal and abdomen, mesentery, peritoneum, mesentery. So yeah, I mean, it is a little bit complex, and so this is the mesentery. So mesentery, the terminologies, mesentery, mesocolon are the same, like the same structure. Of course, if they are going from the posterior abdominal wall to the colon, then we call it mesocolon. If we are going to the small intestine, we say mesentery, but essentially the structure is the same. It is the two layer of peritoneum just stacked together. Inside two layers, there will be fat, there will be blood vessels like the branches of the superior mesenteric, inferior mesenteric with their branches together with the fat, some lymph nodes just sandwiched in between the two layers of the peritoneum. So let's look at this diagram. We are looking the patient in a sagittal position. They have tried to identify the numbers of the vertebral bodies. So this is the sacrum. So one above the sacrum is lumbar 5, lumbar 4, lumbar 3, lumbar 2, lumbar 1, thoracic 12, thoracic 11, and so on and on. So this is the anterior, this is the posterior. Now, if you visceral peritoneum and parietal peritoneum, so these are the two layers. So if you follow the parietal peritoneum, start with, it's just like an egg, like you are trying to identify the beginning of a cycle and you can't find it. So you're just tracing the cycle and trying to identify the beginning, and we can't find it. That's the same thing here. Let's say, where is the beginning of this peritoneum? So parietal peritoneum, we just follow along here. it is going to the posterior abdominal wall, and it is just folded, come down, and it covers the intestine, small intestine, multiple small intestine being covered with the peritoneum, and then go back to the posterior abdominal wall, cover some of the intestine in the back, stack them to the back, then come out again, just become cover again and go down as a flap sheet, and keep going like that, and then liver, and then go up downwards, anterior abdominal wall, and now we are back to square where we start. So this parietal peritoneum is something covering peritoneum layer which covers the abdominal wall, and there is another layer of peritoneum which is, look at that, visceral peritoneum. It is again like it is, which is visceral, which is parietal. It is so difficult to say, but it is the easy way to remember is the peritoneum portion, which covers the anterior abdominal wall, which covers the posterior abdominal wall. They are called parietal peritoneum. The peritoneum, which covers the intestine, like visceral organs, that is called visceral peritoneum. That's the easy way to remember and keep our mind simple. Look at this peritoneum from the anterior abdominal wall, covering the diaphragm of the anterior abdominal wall, and now it folds and it covers the liver. So this portion, which is covering the diaphragm, is the parietal peritoneum, and the same thing, which once it's fold down and once it's cover the liver, it is called visceral peritoneum. So the same structure, but depending on which one it's covered, the name change from parietal peritoneum and visceral peritoneum. So here, what I want to remember is this anterior fold of the peritoneum came here and fold it back. This posterior fold of the peritoneum came to the liver from the back and fold it back. So there is a small area of liver which is not covered with the peritoneum. That area is called empty area of the liver, bare area of the liver. And if we follow this parietal peritoneum, which is line covering the posterior abdominal wall, and then go down to the liver, go up to the liver, and then fold up. Now this became visceral peritoneum. And the fold anterior visceral peritoneum covers the inferior surface of the liver. And these two folds meet here. That is called the omentum. So this omentum just combined here, split again, anterior and posterior to cover the transverse colon, and combine here. Keep going, come here, split again, go here. So this fold of peritoneum, together with fat, blood vessels, and lymph node, it is called mesentery. So it's called omentum. So this is a greater omentum, which we saw from the previous diagrams. So from this diagram, again, we have to appreciate that our urinary bladder is outside the peritoneal cavity. This is the peritoneal cavity. So our urinary bladder is outside the peritoneal cavity. This rectum is outside the peritoneal cavity. And this is the duodenum. Duodenum is posterior to the peritoneal cavity. And this little yellow structure here, that is the pancreas. Pancreas is posterior to the peritoneal cavity. So we call them retroperitoneal structure. And this transverse colon and small intestines. This is the stomach, and this is the transverse colon. They are inside the peritoneal cavity. Now we are dividing inside the intra-abdominal contents into the retroperitoneal structures and intraperitoneal structure. It is just the mesentery which has make a mess, and they split it into intraperitoneal and retroperitoneal structure. Of course, both they are in the abdomen, intra-abdominal organs. So now again, I just keep following the peritoneum, which is covering what, and another peritoneum, which is covering what. And finally, I got this. So don't worry about that. Don't go too crazy. But just what I want you to remember is the peritoneum inside the abdomen, 2 layers as usual. The peritoneum, which covers the abdominal wall, it is the parietal peritoneum. The peritoneum, which covers the visceral organ, is called visceral peritoneum. And sometimes they do fold, and then they enclose. Some of the structures will become retroperitoneal. Some of the peritoneum just become hang down with the mesentery, very long peritoneum, which is called mesentery. So now we got the same structure, like we are looking at the abdomen, sagittal section. We can see the spine here. This is the sacrum. So this must be lumbar 5, lumbar 4, lumbar 3, lumbar 2, lumbar 1. Oh. So, and we said liver, this anterior abdominal wall, this parietal peritoneum covering the anterior abdominal wall, go up in front of the liver, go to the top, and finally it folds back and then covers the liver. So this parietal peritoneum continue as visceral peritoneum, cover the front of the liver, inferior surface of the liver. And this posterior abdominal wall, parietal peritoneum, go up to the liver, fold down and come down and cover the posterior surface of the liver. So this parietal peritoneum became visceral peritoneum. This is the bare area of the liver, where there is just underneath the diaphragm, where there is no peritoneal covering. And this visceral peritoneum and this visceral peritoneum fuse here to form the lesser omentum. Open it up again and covers the stomach, come down here, fold it up, split it again, and then cover the transverse colon, go back, the duodenum, pancreas being pushed back to the posterior abdominal wall. They do not have mesentery. Come down here, small intestine, like a mesentery, and then come down, swallow and cover it. Hey, so look at that. As we say, our urinary bladder is outside the peritoneal cavity, and our uterus is outside the peritoneal cavity. So the light blue color area is the peritoneal cavity. Yeah, so our rectum, uterus, bladder, they are out of the peritoneal cavity. So these are not the intraperitoneal structures. And even if you look inside the peritoneal cavity, the peritoneum, which is hanging down the small intestine, is called mesentery. But that full of peritoneum hanging the colon is called mesocolon. It is hanging the transverse colon, so we call it transverse mesocolon. And this transverse mesocolon and this fold, this is what we call greater omentum. So anything anterior to the greater omentum is called, we said, greater sac, and anything posterior, so anything inside the big cavity is called greater sac, and this fold split the greater sac peritoneum, this greater omentum fold split the greater sac into anterior supracholic compartment and posterior infracholic compartment. Supra above the colon and infra below the colon. So now you can see the greater sac, which is color with the light blue color. And here with the dark blue color, we call it lesser sac. So posterior to the stomach, in front of the duodenum. So what I want you to remember is greater sac and lesser sac. That's it. So if we do a transverse section, so we cut the abdomen in the axial section, and we are looking from the bottom of the patient. So this is the right side, this is the right side, this is the left side, this is posterior because we can see the vertebra here. So this is the anterior, this is the right rectus, this is the left rectus, and this is the stomach, which is cut in a transverse section. And now we can appreciate the kidneys, right kidney and left kidney, which are the retroperitoneal structure. And this is the liver, this is the spleen. Of course, you know, this diagram, bang, this CT scan, transverse section of the CT scan, which might be a little bit more interesting and easy to check. This is the right side, this is the left side, this is the back, posterior, because we can see the spine, and this is the anterior abdominal wall, this is the right rectus, this is the left rectus, in the center, this is the linea alba, and I can see the stomach here, which is filled with might be barium or food, and there is gas in the stomach because there is always some gas in the stomach. So air and fluid level. And we can see the liver here, big liver on the right side. We can see a spleen, no, we cannot see. Kidneys, this is the pancreas. So now this CT scan is a little bit easy for you guys. A little bit more detail, you know, this is the spine, this is the kidney, left kidney, which is stuck to the posterior abdominal wall. But here we can see the parietal peritoneum, which is pushing the descending colon on the right side, ascending colon, and duodenum stuck with the mesentery back to the posterior abdominal wall. And they are not called the mesentery anymore. This is the posterior abdominal wall, peritoneum. So that is the structure of the abdomen. And let's move on to a little bit more light-hearted slides. You know, like we have the whole morning, we have been trying to dig into the anatomy of the abdomen, and it is pretty harsh. So we'll take it easy. We take it easy step. So our gastrointestinal tract from the mouth, oral cavity, oropharynx, esophagus, go into the stomach, duodenum, jejunum, ileum, and then large cecum and ascending colon, transverse colon, descending colon. And these are the functions they do. So I want you to check this diagram. It is also in our textbook. It is not difficult, you know, we all know, but, you know, usually small intestine, they will digest and they will absorb all the nutrients. Large intestine is more of water reabsorption. The small intestine is more of nutrient reabsorption. Stomach is mainly digestion. Of course, there are a few little things, you know, it does absorption or something like that. But I just want you to have a look at this diagram. Here now we can see a little bit more detail about the food in the oral cavity being swallowed along the esophagus. So the job of the esophagus is for swallowing, peristalsis, propulsion into the stomach. Stomach means starting the digestion, duodenum, and the small intestine, absorption, and small intestine here, large intestine becoming fecal matter and more of water reabsorption. And finally, cecum, rectum, it is more for storage for the fecal matter, and anus with defecation. So our digestion process, eating, alimentary tract, the function of our alimentary tract is ingestion, mechanical breakdown, propulsion, digestion, absorption, and defecation. So these are the job of our gastrointestinal tract, which start from the oral cavity down to the anus. So it is a long track, this long track starting from the mouth, oral cavity down to the anus. It is long and windy structure. So we divide into foregut, midgut, and hindgut. Why? How can we divide this? How can we say foregut, midgut, hindgut? Of course, foregut, midgut, hindgut. That is based on our little fetus embryology. So our trachea and respiratory tract, so our lungs, they develop from the foregut. Lungs develop from the foregut. Our esophagus develop from the foregut. Our stomach develop from the foregut. Our liver from the foregut. Gallbladder, pancreas, duodenum develop from the foregut. So embryological structure, like a little tube, we start with the little tube, and then this tube is divided into 3 portions: foregut, midgut, and hindgut. These are the structures developed from the foregut. From the midgut, we get lower duodenum, jejunum, ileum, cecum, appendix, ascending colon, proximate to that of the transverse colon. These structures derive from the midgut, and hindgut is the rest. Distal 1/3 of the transverse colon, descending sigmoid, rectum, Eden canal, and urogenital sinus. So if you can remember our celiac tract, superior mesenteric, inferior mesenteric. So superior mesenteric is the artery for the midgut. So all the midgut structure will be supplied by the superior mesenteric. All the hindgut structures will be supplied by the inferior mesenteric. Look at that, celiac will go to the stomach, celiac will go to the liver, gallbladder, and pancreas, duodenum. So the foregut structure will be supplied by the celiac, but of course, respiratory tract, esophagus, they are in the thorax, so they will have different blood supply. So this foregut, midgut, and hindgut, it is pretty useful if we want to think about the origin from the developmental origin from the fetus and blood supply of the gastrointestinal tract. And again, because we talk about the peritoneum, so intraperitoneal organ and those organs in the abdomen which are stacked to the posterior abdominal wall, which are retroperitoneal organs. So I want you to remember that duodenum is stacked to the posterior abdominal wall. There is no mesentery. That mesentery is too short, and that short mesentery stack the duodenum to the posterior abdominal wall. Ascending colon, no mesentery, stack to the posterior abdominal wall. Descending colon, stack to the posterior abdominal wall. Rectum, stack to the posterior abdominal wall. And rectum and anal canal, pancreas is also stacked to the posterior abdominal wall. Kidney, stacked to the posterior abdominal wall. And these are the intraperitoneal organs: liver, stomach, ileum, transverse colon, and sigmoid colon. Hey, when we say ileum, look at the spelling, I-L-E-U-M. So ileum, I-L-E-U-M, it is for the intestine. I-L-I-U-M, ileum is the bone, yeah? So don't confuse the spelling. I-L-E-U-M and I-L-I-U-M, ileum. Okay, so peritoneal cavity and the peritoneum. Peritoneum is serous membrane. It is just like pleura or pericardium. It is a mesothelial tissue. Mesothelial tissue, it derived from the mesoderm. So mesothelial tissue derived from the mesoderm. Don't worry about that. And it has got parietal peritoneum and visceral peritoneum. And peritoneum is the cavity, the space between the two surfaces. Mesenteries are the double layer of the peritoneum. So two peritoneum fold stacked together. In between the two peritoneum fold, it will contain some blood vessels, fat, and lymph nodes. So it contains blood vessels, nerve, and fat. So some of the mesentery go from the organ to the anterior abdominal wall. Some of the mesentery go from the organ to the posterior abdominal wall. So those mesentery from the organ going to the anterior abdominal wall, we will say ventral mesentery. Those mesentery from the organ going to the posterior abdominal wall we call dorsal mesentery. So mesentery can be divided into dorsal mesentery and ventral mesentery. Ventral mesentery, of course, we know that it is from the liver organ going to the anterior abdominal wall. For example, falciform ligament. It is the ventral mesentery. From the liver going to the stomach. It is also called ventral mesentery. Dorsal mesentery from the organ, sigmoid organ, going to the posterior abdominal wall, sigmoid mesocolon. From the transverse colon going to the posterior abdominal wall, transverse mesocolon. From at the greater omentum, which is hanging down here, it is the dorsal mesentery and mesentery of the small intestine, because from the small intestine going to the posterior abdominal wall. So these are the dorsal mesentery. So if we look at that again, so this is the small intestine going to the posterior abdominal wall. It is dorsal mesentery. So from the liver coming to the stomach, this is the ventral mesentery. From the liver going to the umbilicus, ventral mesentery. So from the transverse colon going to the posterior abdominal wall, transverse mesocolon, it is the dorsal mesentery. So dorsal mesentery, ventral mesentery, it is making us a little bit dizzy. But anyway, this organ going to the posterior abdominal wall mesentery, it is dorsal mesentery. Greater omentum, mesentery of the small intestine, transverse colon, and sigmoid mesocolon. So these are the dorsal mesentery. So that is the arrangement inside the abdomen. Some are peritoneal, some are retroperitoneal. So intestine, some of the intestines are in the intraperitoneal, some are stacked to the posterior abdominal wall, retroperitoneal. So I want you to remember like structures which are stacked to the posterior abdominal wall, retroperitoneal structures, and structures stacked to the structures inside the peritoneum, which is the intraperitoneal structures. So we talk a lot about gastrointestinal tract. Let's have a little break and we'll talk about something else. Because we will talk about in detail about this fertilization when it comes to the reproductive system. And this is the, let's say, the introduction to the, what do you call that? The fertilization and fetus and conceptus. So I'm not going very detailed. It's just a rough idea, because when we talk about the intestine, during the development, this intestine in our tummy, at some point they were out of the abdomen and they have to come back into the abdomen, and abdominal wall have to close it. So that is the pretty daunting, daunting issue, like when we were little baby, little fetus inside our mom, all our intestine at some point, they were out of the tummy, out of our abdomen. And then with time, gradually all the intestine, we have to go back into our abdomen, and then the anterior abdominal wall has to close it. So that's why I just want to include this fertilization in the gastrointestinal tract. So let's look at that. This is very lighthearted, like a lady ovulate. This is the ovary, and this is the uterus. That's the fallopian tube. Fallopian tube is wide at the distal portion, and once it gets close to the uterus is here, it's gradually become more and more narrow. That is again like, and if you think about the uterus has got 3 layers, guys. It is endometrium. Hey, look at the endometrium. And this is the muscle layer, so myometrium. And the outermost layer, which is serosa. So 3 layers. Uterus has also 3 layers. Innermost lining, which is endometrium. Of course, it is endothelial cell. So the same like blood vessel, and the endothelial cell, and the muscle layer, myometrium, and outermost serosa layer. So this arrangement, the ovary is attached to the uterus, and ovary, like every month, one ovum mature, and then it's just flip out, come out of the ovary, and this little end at the end of the fallopian tube, we have little fibrils, like a finger-like projections. They will all go and grab the ovum and put it into the fallopian tube. And once the fallopian tube meet with the sperm, and the union is called, egg and sperm union is called conception. Yeah, that is the conception. So if you look at that, this concept and conception oocytes gradually become bigger and bigger. We come along the fallopian tube, go along here, finally get into the uterine cavity after day 4. And it will gradually embed into the uterine endometrium, and that is called implantation. So the conception means egg and sperm union, embryo. So the usual normal pregnancy is, let's say, 38 weeks. First 8 weeks, this little concept is called embryo. And after 8 weeks, we call that fetus. So just a little terminology, which we will repeat that when we talk about the reproductive system. Embryo, first 8 weeks. After 8 weeks, it is called fetus until 38 weeks. And once it is born, it is called neonate, newborn. And fertilization means chromosome of male and female gametes come together in the ovum. And of course, this little fertilized ovum gradually gets bigger and bigger and bigger. And finally, at day 4, it gets into the uterine cavity. The cell inside the ovum gradually divide. And finally, it will just get attached to the uterine endometrium and gradually go and invade into the uterine endometrium, and gradually, just like the cell inside split into 2 initially, one blue and one gold layer. So one blue cell layer and one gold cell layer. And then this blue cell, gold cell layer and blue cell layer, 2 initially. At 2 weeks after the conception, we have 2 layers, and gradually this 2 layer will gradually change into how many layers? Of course, 3 layers. What is surprise? We if we don't know, we said 3 layer. So now we are saying from 2 layer, it finally became 3 layer. This 3 layer, they are called ectoderm, endoderm, and mesoderm. So the mesothelial cell, which we change into peritoneum. They are from the mesodermal origin. And if you look at that, guys, the color of this, I think it is carefully arranged, Endoderm is the yellow color, mesoderm is the red color, and ectoderm is blue color. Endoderm, which means like mesoderm, is red, so it is going to become muscly. Yeah, bone and muscles and kidney, red solid structure, mesoderm. These are the mesodermal derivatives. Our bones, our muscles, our kidney, big solid red colored structure in our real life, they will derive from the mesoderm. Endoderm, look at that. What are they look like? They look like an epithelial cell. So endoderm will develop into epithelial lining, inner lining of the tube, like our esophagus, our bronchus, or every tubular structure, inner lining will be derived from the endoderm. And the ectoderm is for the brain, and that sort of brain and spinal cord, that sort of structures. Whatever it is, at this stage, I want you to remember three structures: mesoderm, endoderm, and ectoderm. And look at that mesoderm. So let's say, like from the fertilization, gradually 2 cells meets 1 cell, and then split into 2, split into 4, and finally split and split and split. And then finally we got to 2 layers at 2 weeks. At 3 layers now we got ectoderm, mesoderm, endoderm at week 3. And this finally will just gradually fold. And then finally gradually fold. If you look at that, it is going to fold. Endoderm, mesoderm, ectoderm. And then it's going to fold like that and finally become a hollow tubular structure body or hollow tubular intestines inside our body. Just 1 minute, please. Like this 3 layers finally became 3 layers: endoderm, mesoderm, and ectoderm. This initially it is like a saucer disc shape, and this disc has to fold it from head end and tail end, and finally, and from side to side. So, and it's gradually become like a, look at that, outer covering, the blue here. And look at this blue will become the spinal cord here, intestine here, the yellow inside in the intestinal lining, the red muscle here, it is the muscle layer of the small intestine, or all the muscles we have, skeletal muscle. And what I want to show you is finally, during the folding, cephalocaudal fold, and this, look at that, this yellow structure is out of this folding. So this yellow structure is going to be, will contain the intestine. And look at that, this intestine will have to go back into the baby's tummy. And finally, I want you to look on this what do you call that? This website. The way the intestine folds and then finally go back into our abdomen. That is the way. That is the way. That's why, once during at some point of our life, the all our intestines, they were out of the abdomen. They have to twist and turn and fall back into the abdomen. So some of the intestine will be stuck to the posterior abdominal wall. Some of the intestine will be hanging inside the abdomen with the mesentery or mesocolon. And finally, of course, we got this. All right. So nearly done now. I will just push 1 or 2 more slides. Blood vessel wall, how many layers? 3. Innermost endothelial layer, tunica intima, marcel layer, tunica media, outermost layer, tunica adventitia. That is the blood vessel wall anatomy. The heart, innermost endocardium, middle myocardium, marcel layer, and outermost pericardium. Pericardium has 2 layers, visceral peritoneum and visceral pericardium and parietal pericardium. And the same thing, intestine, we have 3 layers, innermost mucosa, marcel layer, muscularis externa, and outermost serosa layer. Of course, we have the mucosa layer, which is made of epithelial cell and the lamina propria. And underneath the mucosa, we have another layer, which is called submucosa. So submucosa in the intestine is really thick structure, and therefore we have to appreciate it. So instead of 3, we try to remember as 4 in the gastrointestinal tract. And of course, it is just like mucosa, marcel layer, and serosa. That is the basic, but mucosa, submucosa layer is pretty thick in the intestine, and therefore we appreciate it and we take it as 4, mucosa, submucosa, and the muscularis externa and the serosa layer. All right, I'm going to stop here because I don't want to push too much in one go. We'll continue this lecture on Friday. So has anyone got any question, or it is too much? All right then. If there is no question, I will let you go then.